So I'm going to talk today, as stated, about dual antiplatelet therapy with an emphasis on the changing role and choices for the ADP inhibitors, the P2Y12 inhibitor component, as well as some of the information that we have regarding aspirin dosing. As you'll recall, the coagulation cascade is a more complex than we were typically taught in school with the extrinsic and intrinsic pathways. Instead, it's really an interconnected pathway in which platelets play a very important role. Not only is the first wave of adhesion, aggregation, and forming a platelet plug, but also serving as an important center at the membranes of the platelet for the concentration of the prothrombinase complex and the other soluble coagulation factors. And so there's a great deal of interaction between the soluble coagulation cascade and platelets, including, for example, activation by thrombin, so that the platelets are a key component in both the initiation and the perpetuation of thrombosis, particularly in arterial systems. So much of what we've accomplished in terms of reducing acute ischemic events in patients with coronary intervention and with acute coronary syndromes has been accomplished, at least in the short term and more recently in the long term, with antiplatelet therapies, and hence the importance of the therapies directed against the platelet. There are three major phases of platelet function: adhesion at the site of vessel injury, followed by activation, where they actually release their various factors which perpetuate this and lead to further coagulation, and then aggregation, where there's actually formation of the platelet plug. Most of the agents that we use clinically are directed against the processes of activation, and these include the arachidonic acid thromboxane pathway inhibitor, aspirin, as well as the ADP inhibitor. So this is also a schematic of the multiple functions. Platelets are multifunctional. It is difficult to knock out all platelet function with one agent, but the most important agents, the agents that have been shown recently to have the most effectiveness, are those which are directed against both thromboxane A2, and that's aspirin, as well as the ADP receptors, and those are the antagonists that include Clopidogrel, Prasugrel, and Ticagrelor, which we'll discuss today. Now, first starting with aspirin. Aspirin, of course, is a legacy drug. We've used it for years, but we have, in recent years, submitted aspirin to large-scale clinical trials. And in all settings of vascular disease, aspirin has clearly been shown to reduce the risk of recurrent events, death, myocardial infarction, by risk ratios of 30 to 50%. Aspirin was established definitively, for example, in myocardial infarction in the OASIS-2 study, where among 16,000 patients, aspirin reduced the risk of mortality in myocardial infarction by approximately 25%, by as much as did streptokinase, and when the two were combined together in the fourth group here actually had an additive effect. So aspirin has an additive effect to other therapies given in acute coronary syndromes. In the meta-analyses and pooled analyses that are conducted by various bodies that produce guidelines, including the American College of Chest Physicians, which recently came out with their guidelines, the role of aspirin, or the effectiveness of aspirin, was assessed using all of the data that had been pooled, and very clearly in patients with established coronary disease, aspirin results in a reduction in mortality, which approximately 13 lives saved per 1,000 patients treated, a substantial reduction in stroke and myocardial infarction, with a modest increase in bleeding. So we have to remember that, as with any other therapy, aspirin does increase the risk of bleeding. Now, this is going to be a recurrent theme. We don't get something for nothing. We reduce ischemic events, but we do have an increase in bleeding complications, and that becomes the issue of weighing the relative efficacy of different agents, different combinations of agents, different dosing of agents, and which patient groups should receive these more intense agents, because there is no free ride. All of the agents that are effective increase bleeding. Aspirin dose does seem to influence the risk of bleeding, particularly in combination as dual antiplatelet therapy. And this was first made clear in the CURE trial in patients who received the combination of clopidogrel plus aspirin in one of the treatment arms. And you can see that the higher doses of aspirin were associated with increased risk of bleeding, particularly in the combination treatment group. Now, there was question over the last several years, though, whether the higher doses of aspirin might be more effective, and this was driven in part by stent trials that used higher doses of aspirin. So this was finally tested in a rigorous fashion in the OASIS 7 trial, the current trial, in which patients with acute coronary syndromes were randomized to receive either low-dose aspirin or a standard 300 to 325 milligram dose of aspirin. And there was no advantage in terms of efficacy of the higher dose of aspirin. But there was an increased risk of gastrointestinal bleeding, as shown in the bottom row. Now, there was only a 30-day endpoint for this trial, so even though this difference may seem small, recognize that if magnified by multiple months or a lifetime, the lifetime risk or the long-term risk of increased gastrointestinal bleeding can be quite substantial. So the bottom line with aspirin now is that it's pretty much shown unequivocally there is no advantage, at least for cardiovascular disease, in a higher dose of aspirin. And there is some evidence for, in combination, that it actually may be a disadvantage from the term of efficacy. So we should be using low-dose aspirin in all of our patients, either alone or in the dual antiplatelet therapy that I'm going to discuss. Now, the second component of dual antiplatelet therapy is thus the ADP receptor. The ADP receptor is one of the potent receptors that activate platelets. That means turn them on, allows the shape change, allows the pseudopod formation, allows the release of various mediators of downstream further thrombosis, of spasm, even of growth activation, and then ultimately to platelet aggregation. So this is a key point in the platelet cascade. You may hear, and so it is the target of the so-called P2Y12 receptors, and you may hear of this term P2Y12. This refers to one of the three subtypes of the ADP receptor shown in the middle here. This of the three subtypes is the one that leads to irreversible change in platelet activation. So this is the most potent, the most important component, and this is the target of all of the agents that we're going to discuss. That are directed against the ADP receptor. Now, the Clopidogrel was actually first tested as an alternative to aspirin, not in combination. And this was in the CAPRIE trial, which was carried out several years ago, published in 1996. It was a very large trial in patients with vascular disease and pretty much an unimpressive result. It ended up being slightly superior to aspirin with an 8 to 9% risk reduction that barely met statistical significance despite almost 20,000 patients enrolled in the trial. And so although it was superior to aspirin only slightly, it really wasn't used. It was much more expensive. And except for patients who were at increased risk for gastrointestinal bleeding because it was easier on the stomach, it was hardly ever used as a monotherapy. So basically, aspirin and clopidogrel can be considered equivalent as monotherapy, although there's some edge for clopidogrel, particularly in patients at increased risk for gastrointestinal bleeding. Where these agents really came in to an important role in medicine was as combination therapy with aspirin. And the first agent that was actually established in that role was Ticlopidine, the predecessor to clopidogrel, which has since been supplanted almost entirely because it's BID dosing, it has GI intolerance, and a few cases of severe bone marrow toxicity. But Ticlopidine was tested in combination with aspirin in the trials of stenting. The trials that established that we didn't have to do it the way we had been with Coumadin and leading to high bleeding risks, that in fact, patients who got the combination of aspirin plus Ticlopidine, shown in the red bars in these different trials, had the lowest rates of ischemic events compared to either aspirin alone, so clearly better than aspirin alone, and better even than using warfarin. The platelet is where it's at, not the anticoagulant for arterial disease. And so this really established the idea of using dual antiplatelet therapy. And over time, as I said, Ticlopidine was replaced with clopidogrel for stenting. Much broader use of clopidogrel in combination with aspirin was established by trials which showed, regardless of whether stents were used, medical therapy or not, patients with acute coronary syndromes in the CURE trial, and then even with elective intervention without stents or with stents in the CRITO trial, over the long term, these patients treated for 9 to 12 months had a significant reduction in ischemic events when given the combination, that is dual antiplatelet therapy as compared to aspirin alone. And that really established in a much broader spectrum of patients the idea of using dual antiplatelet therapy for acute coronary syndromes, as well as long-term after coronary intervention. This was also extended to ST elevation myocardial infarction in a large trial known as COMMIT, in which patients with fibrinolytic therapy, not primary PCI, but again, moving beyond the coronary intervention, but patients receiving fibrinolytic therapy had a significant reduction in mortality and in ischemic events if they got clopidogrel as well as aspirin. Now, the drive toward administration of these events early really came from observations that were somewhat twofold. First, that in patients even treated medically in the CURE trial with acute coronary syndrome, the benefit of combining aspirin and clopidogrel began to accrue very early. So on the left of this slide is the full 12-month Kaplan-Meier curves where you can see the 30% reduction, or 20% reduction in events. But in the right side is the first 24 hours. And you can see that the curves diverge immediately upon starting to give clopidogrel. So patients who present with acute coronary syndrome are at risk very early on, and they benefit from dual antiplatelet therapy as compared to aspirin very early on, even in the medical phase of management. And this is the drive toward this early administration, which conflicts with our concerns regarding what would happen if a patient needs bypass surgery and increased risk of bleeding. So that's why there's been some concern regarding early administration, but the data is based on the findings of increased risk and early benefit. Moreover, and this is a little hard to see the details, but the bottom line are shown in the text below each box, in patients who ultimately go to percutaneous coronary intervention, it is better to have received clopidogrel ahead of time. It is better from the standpoint of myocardial infarction. There is no decrease in mortality, but post-procedural myocardial infarction is reduced in patients who have received clopidogrel before they go to the cath lab. So in general, the guidelines recommend early use of dual antiplatelet therapy in patients with acute coronary syndrome and in patients going for percutaneous coronary intervention, even electively, rather than giving them later in the course. Although, again, we're not reducing mortality, but we may be reducing the risk of myocardial infarction. Now, what about the duration then? We know we should be using it as early as possible. What about the duration of therapy? And this is where we come into much less in the way of therapy. In general, the data would suggest, and these are really from the two large trials that I showed you earlier, CURE and CREDO, that there is a benefit of long-term therapy in patients after drug-eluting or bare metal stenting. And this is summarized in this pooled analysis, again, from the American College of Chest Physicians, in which there was a significant a reduction in the risk of myocardial infarction and a modest risk in the increased risk of bleeding. But the question of whether or not to prolong longer than 1 year still remains unanswered. And there have been two trials, relatively small, only 2,700 patients, that have looked at longer than 1 year and have not shown a benefit. So although we commonly continue these drugs long-term after drug-eluting stents, in fact, we're doing so without any data. There is a large trial going on now. The results won't be available for several years. But as it stands now, the data suggests that there is no benefit of longer-term dual antiplatelet therapy, that is, after 1 year, even with drug-eluting stents. So we all know, though, that there are newer agents than clopidogrel, and part of the understanding this is to understand the rationale for development of these agents, and they really relate to the pharmacokinetics and the pharmacodynamics of clopidogrel. Clopidogrel is a thienopyridine. It is absorbed as a prodrug. It's actually not biologically active as absorbed. It has to be metabolically transformed to its active form, the active metabolite. And that metabolic transformation occurs by multiple steps within the liver. The problem is twofold. First of all, there are multiple steps, and interference with any of these enzymes by either genetic differences or by other drugs which interfere with these enzymes can reduce or slow down that transformation. And second is that 85% of the drug is actually converted to an inactive metabolite, shown on the left of this slide, by enzymes in the gut and in the erythrocytes, in the blood. And so much of the drug never makes it to its active form, and that which does takes a while to get there, and that while can be longer in some patients than in others. And that leads to a lot of variation in the degree of platelet inhibition with clopidogrel from patient to patient. And in fact, that variation has been well established. This slide shows the responses to the same loading dose, 600 milligrams, on the left-hand side in several different patients. And you can see it's markedly different. It looks like you're giving different doses. Exactly the same dose can take, this is over a period of hours, up to 7 hours, can take 7 hours in some patients, a half hour or an hour in other patients, and the degree of inhibition can vary by over 100% from patient to patient. Moreover, even after the drug is discontinued, you can, on the right-hand side, you can see that the variability in responses over the days that follow is quite substantial as well. So this, in effect, is a very dirty drug in that it's hard to know what kind of dose response we're going to get. This raises the question of clopidogrel resistance, and is that clinically important? And this continues to be a topic of controversy and uncertainty. But what I'll try to do is summarize what we think we know and then emphasize what we really don't know and how that influences therapy. So what we think we know is that patients who are clopidogrel resistant, as measured by a variety of different techniques, are at higher risk for ischemic events. That doesn't mean that the clopidogrel resistance caused those increased ischemic events, because that's causation, which we can't prove. But there is an association, and that's illustrated in this slide, where in this pooled analysis, the risk in patients who had a worsened or inadequate response to clopidogrel had up to a 5-fold increase in ischemic events over long term after percutaneous coronary intervention. The other thing is that we know that some drugs can interfere with platelet inhibition by clopidogrel, and the one that's of most concern, for example, is Omeprazole or Prilosec, the PPI. And in the package insert, for example, with the FDA, about a 40% reduction in the maximum concentration of the active metabolite of clopidogrel, 40% or so over the long term, and about a 40% reduction in platelet inhibition. Now, this is specific. It's not the class of PPI. It doesn't respond. It isn't a factor of absorption. Pantoprazole, for example, which has less interference with the enzymes, actually has much less in the way of interference of platelet inhibition. Again, though, the association with outcome has only been shown to be an association, not causation. And in fact, in a randomized trial, when patients receiving clopidogrel were randomized to receive omeprazole or placebo, known as the COGENT trial, this trial was actually directed at seeing if the omeprazole would reduce GI events, and it did quite potently, as shown in the table at the bottom here, anywhere between 70 to 80% reductions in either GI composite or GI bleeding. So clearly, if you're getting clopidogrel, it's beneficial to get omeprazole from the GI standpoint. And from the standpoint of ischemic events, cardiac ischemic events, there was no difference whatsoever. So despite a 20 to 40% reduction in the effect of clopidogrel with omeprazole, we can't prove that that actually has any causative effect on ischemic events. The second is the question of genetic polymorphisms, and there have clearly been identified patients who have less of an enzymatic transformation, so-called intermediate metabolizers or poor metabolizers, the IM and the PM in these slides, as compared to the normal metabolizers or the even ultra metabolizers. And clearly, for different doses of clopidogrel, either as loading or as a maintenance therapy, they result in different levels of platelet inhibition with clopidogrel. So the genetic state does influence the amount of inhibition by clopidogrel. And just as with platelet resistance in general, the patients who are carriers of these genetic polymorphisms do seem to be at higher risk than those who are not carriers of these polymorphisms over longer term for follow-up. So this raises the question again, is it through the platelet inhibition, or is it a side effect, a side phenomenon, or just an association? It's frustrating that we cannot show that interfering with the degree of platelet inhibition or improving the degree of platelet inhibition necessarily changes the outcome. And this was addressed in the GRAVITAS trial, in which patients who had high platelet reactivity were then randomized to doubling the dose of clopidogrel or keeping the standard dose. So these were patients who had percutaneous coronary intervention, about 5,000 patients. About 2,000 of them were found to have high on-treatment reactivity. That means their platelets were still quite reactive despite being treated. So they were considered resistant, whereas about 3,000 were not resistant. The patients who were resistant were then randomized to either get high-dose clopidogrel or the standard dose, whereas the patients who seemed to have a good response were just continued to be treated with the standard dose. Now, looking at the effect of doubling the dose of clopidogrel, it actually worked from the biochemical standpoint. So on the first bar of these, so on the left of this is the high dose group, on the right is the standard dose group. The first gray bar is the patient's the degree of platelet inhibition, and that purple line was the cutoff for resistance. And you can see before the randomization, the patients who were in the were all above the bar. They were all considered to be resistant by the fact that they were above the bar. Once they received the high dose, however, virtually everybody fell below the bar. So the high dose therapy actually improved the effect of clopidogrel and made those patients no longer resistant, whereas the standard dose therapy on the right did not. So doubling the dose of clopidogrel actually worked from the standpoint of biochemistry. Platelet inhibition was improved. And patients who were high as compared to patients who were not seemed to have a worse outcome, as shown in this slide. But the randomization didn't make any difference. So being changed to high-dose clopidogrel as compared to staying on the lower-dose clopidogrel did not improve outcome. So here we have all these associations, but thus far we have no evidence that treating anything on the basis of these associations changes the outcome. And that's important, and that's worked its way into the guidelines, which basically say that although we know that there are these associations, they do not summarize all the risk, and there is no evidence as of yet that changing your therapy on the basis of any of these markers of platelet resistance, that is either measuring it or measuring their genetics, will improve outcome. And this is important as you perhaps have representatives trying to push the genetic tests, which are quite expensive, or even the point of care tests. You can do them, and you can identify patients who might be at high risk, but thus far we have no evidence that treating on the basis of that finding will improve their outcome. So what about the new agents? Well, the new agents are Prasugrel and Ticagrelor, and their metabolisms are illustrated here. So on the bottom is the clopidogrel, which again starts off inactive in green, goes through the liver and is metabolized, and then becomes red active. Prasugrel is also a thienopyridine. It's initially inactive, but it has a much simpler metabolism and actually starts its transformation in the blood. Very simple enzymatic transformation, and is transformed very quickly to an active metabolite. And then there's Ticagrelor, which is actually absorbed in a active moiety, so it doesn't require any transformation. So very quickly, basically, as long as it takes to absorb the drug, this drug becomes an active platelet inhibitor. Both of these drugs have two major advantages compared to clopidogrel. First of all, as shown for Prasugrel on the left and Ticagrelor on the right, the degree of platelet inhibition achieved is about twice as much. So instead of 30% inhibition, it's as much as 60% inhibition with the newer agents. Second is it's much faster. So you can see that with Prasugrel, for example, on the left, by within a half an hour, patients achieve the degree of inhibition that would take them hours to achieve with clopidogrel, and by 1 or 2 to 3 or 4 hours, they've received their maximum inhibition. And similarly for Ticagrelor, very rapid inhibition. Now, Ticagrelor is actually reversible. It doesn't irreversibly inhibit the platelet as the other two agents do. And so actually, when you stop the drug, despite much more potent inhibition at equilibrium, within a dose and a half, so about a day and a half, 3 doses or a day and a half, the degree of inhibition shown in the fall-off on the right it becomes less than that of clopidogrel. So more inhibition and then washing out more quickly over a period of a couple of days. Now, 2 major trials have tested these 2 agents in patients with acute coronary syndromes. Prasugrel tested in TRITON, Ticagrelor tested in PLATO. Although both trials were large and both enrolled patients with ST elevation and non-ST elevation myocardial infarction, there were differences, and those differences are important to understanding when to use these drugs. For Prasugrel trial, it was only tested in patients undergoing PCI, so there is no data relevant for patients who are being treated medically. And none of these patients had received pretreatment with clopidogrel. In the Ticagrelor trial, about 30% of patients actually were treated medically, and they got their drug at the time they showed up and were randomized. And about half of them had received clopidogrel ahead of time. So the data for Ticagrelor can be more broadly extrapolated to practice. That is, unless a patient is with ST elevation myocardial infarction when we're treating immediately, as was done in the TRITON trial, there's a little bit of difficulty extrapolating to what we do in practice, which is treat patients before we necessarily know what their coronary anatomy is. But both trials showed similar findings with regard to effectiveness or efficacy. In the TRITON trial with clopidogrel, with Ticagrelor, about a 20% reduction in ischemic events and an increase in bleeding events. Now, the increase in bleeding events shown at the bottom was much smaller than the benefit, but nevertheless, it was important. And we looked at the components of the ischemic events that were reduced. It was it was myocardial infarction and stent thrombosis. Death was not decreased, perhaps because bleeding was increased. Transfusions were increased, non-CABG bleeding was increased, and particularly if a patient needed bypass surgery, that was bleeding increased as well. Importantly, there was a subgroup that actually had no benefit whatsoever and seemed to be harmed, and those were patients who had ever had a TIA or stroke. And that actually is an absolute contraindication on the basis of these data. As you can see, the Prasugrel patients not only had a higher risk of bleeding, but they actually had a higher risk of ischemia as well. Moreover, patients of advanced age, 75 years or greater, or low body weight also had no net benefit. Their bleeding almost outweighed their ischemic benefit, and so it's considered a relative contraindication. Now, another trial tested Prasugrel in patients being treated medically, known as Trilogy, and without going into the details, the bottom line is it didn't show a benefit. So really the benefit that we have with Prasugrel is confined to patients undergoing percutaneous coronary intervention. Now, for the Ticagrelor study, the PLATO trial, again, a 20% reduction in ischemic events shown in the left, and a modest increase in bleeding events that overall was not statistically significant. And this has been attributed to the reversibility of Ticagrelor. When we look at the components, we also saw an improvement in mortality, suggesting again that if we decrease bleeding, we may actually decrease longer-term mortality. So there was no increase in transfusions. There was no increase in bleeding associated with bypass surgery. There was an increase in some bleeding that wasn't associated with bypass, but the serious consequences of bleeding seemed to be reduced with Ticagrelor. Now, an important finding, though, in Ticagrelor was that the group in the United States did not appear to have a benefit. And when that was analyzed in more detail, it turned out that almost certainly that was due to aspirin dosing. Patients in the United States were receiving high doses of aspirin. And when it was broken down by high doses of aspirin, you can see the patients in the dotted line at the top, Ticagrelor with high dose aspirin actually did the worst, whereas Ticagrelor with low dose aspirin did the best. And so the guidelines are very clear that we should be using low dose aspirin whenever Ticagrelor is used. In fact, we should be using low dose aspirin exclusively, regardless of Ticagrelor. Now, there's always concern regarding bypass surgery, and so it's relevant to take a minute to think about what exactly we have to fear from these agents in the setting of bypass surgery. For example, Clopidogrel, there has been quite a lot of concern, and most surgeons won't operate. But in fact, when a meta-analysis of patients who received Clopidogrel within 7 days of surgery, looking at chest drain output or transfusions, saw that in the early era, what they call the early or the mid eras, up to about 2006, where there wasn't much experience, these were increased. But interestingly, in the more recent era, these weren't actually significantly increased or were borderline increased. So the bleeding effects of Clopidogrel are probably not as much as many of us traditionally thought. Nevertheless, with Prasugrel, it is clearly worse than Clopidogrel, and that's shown on the left here. Much higher rates of bleeding, TIMI bleeding, reoperation, much higher, 8-fold higher increased risk of operation and transfusions if patients need bypass surgery, but not with Ticagrelor. Remember, Ticagrelor washes out as fast or faster than Clopidogrel. And shown on the right, the Ticagrelor patients with black bars, regardless of the number of days of washout, from 1 to 7 shown at the bottom, always had the same or even less bleeding than patients who had had Clopidogrel. So to sum this up then, we can make recommendations regarding these two classes of drugs. Aspirin should be given as an initial load of up to 325 milligrams, particularly if the patients are aspirin naive, but thereafter should only be 81 milligrams per day, or 75 if you're in Europe and have access to the different dosing. The ADP inhibitors, their indications depend in part upon the ischemic syndrome as well as the type of intervention. So Clopidogrel is recommended across the spectrum: elective intervention, unstable angina, non-ST elevation MI or ST elevation MI. 600 milligram bolus as early as possible, either on presentation or before PCI if possible, and for up to a year thereafter for all of these. Prasugrel and Ticagrelor have no established roles in patients who do not have acute coronary syndrome. So elective PCI is not an indication. Now, there are exceptions that are based upon clinical judgment but not trials, patients who are intolerant of Clopidogrel, but in general, they are confined to acute coronary syndromes. Prasugrel would be given at the time of PCI only. It is contraindicated in patients with a prior stroke or TIA and avoided in patients who are low body weight and advanced age. And if there's concern of bypass surgery, it should probably be avoided as well. Ticagrelor has a broader indication that is for patients undergoing revascularization or medical therapy, can be given at the time of presentation, and again, emphasizing the importance of the 81 milligram dose. Duration of therapy for bare metal stents is at least 1 month, ideally though 12 months, recognizing there is longer term data. Drug-eluting stents up to 12 months, although there really is no evidence for benefit for any longer thereafter. Thank you very much for your attention.